All right. Good afternoon, everyone. Welcome to Emory's Living with Dementia webinar series brought to you through the Emory Cognitive Neurology and Integrated Memory Care Clinics and made possible by a generous grant from the Gosweda Alzheimer's Disease Research Center. I'm Alice Cooper, one of the social workers in the Cognitive Neurology Clinic, and I'm joined by my colleague, my social work colleague, Jenny Gay, in the Integrated Memory Care Clinic. And these monthly webinars focus on topics that have come up frequently in sessions with our patients and families. So we felt that there's probably many more people who could benefit from hearing the information on these topics. And today's topic is creative communication for care partners. But before I introduce our speakers, one housekeeping detail. There will be time for questions at the end of the webinar. But you don't have to wait until the end of the webinar to ask your question. We encourage you to please put your questions in the Q&A box that's usually located at the bottom of your screen. Do this when you think about them. Jenny will collect the questions at the end and we'll provide them to our speakers. And so now I am very excited to introduce our speakers for today. One is Ashley Varner, who is known to many of you as the other social worker in the Cognitive Neurology Clinic. I have to say that I am very fortunate to have her as my social work partner. She is amazing. Her particular interest is in the experience of caregivers. Stephanie Viverberg is a nurse practitioner in Emory's Cognitive Neurology Clinic and the Cognitive Empowerment Program. She believes that patients and caregivers are her greatest teachers, and she strives to help people living with dementia and their care partners to find joy, purpose, and meaning in their journey. Ellie Santee is a geriatric psychiatrist working in the Fuqua Center for Late Life Depression at Emory. She is passionate about working with people living with dementia and their caregivers. And so I am now going to turn it over to our speakers.
Thanks so much, Alice. It is really an honor. Thanks to everyone for being here today. And it's really an honor to get to work with Dr. Santee and Stephanie Viverberg. This is a reprise of a talk that we gave a couple of weeks ago at the Georgia MemoryNet conference. And we had a lot of fun working together. So it was a natural to kind of reformat it and share this information with y'all. Alice mentioned, I think, that I'm actually on vacation, and what that means is that my bandwidth is a little iffy, so I may not be on camera for all of today. But we're going to talk today about creative communication for care partners, and in particular, what we're looking at are the behavioral and psychological symptoms. Sometimes you'll hear that abbreviated BPSD of dementia. And I think one of the things, just as an overview, that's really key to for all of us to recognize is that as many as 70% of all dementia patients will experience, or patients living with dementia will experience behavioral and psychological symptoms. So they are very common, and they present differently for different people, for different varieties or flavors of the illness, whether it's Alzheimer's or frontotemporal dementia. They can look very different. And they can also look different at different points in the trajectory of the illness. So what depression looks like at the beginning with mild cognitive impairment can be very different than what depression looks like when somebody has late moderate stage dementia, let's say. What we also know is that if these symptoms are left unaddressed, that it really impacts, and I know folks here know this, the quality of life for both people living with dementia and care partners and entire families. And also it may increase the rate of progression of dementia if they're left untreated. Care partners and patients living with dementia rarely begin with knowledge about mild cognitive impairment and dementia. So there's not a class in high school that says 50 years from now, when your partner develops dementia, here's what you need to know. So educating ourselves about the management of these symptoms is crucial, and it can decrease the need for medication and prevent or at least delay the need for additional care or out-of-home placement.
Thanks, Ashley, and thanks to everyone who is attending today. It's a pleasure to get to share with you guys. And as Alice mentioned in introducing me, I do think that a lot of what we've learned as providers is from training and all the things that come with being a provider for someone living with dementia and their caregivers, but also you all are some of our greatest teachers. And so a lot of the tips and tricks we may share today are ones that you all taught us. And as I'm looking at the list of attendees, I recognize many of your names and excited to see you here, and also want to thank you in advance for what you've taught me in my 14 years here at Emory. As you can see, there are several symptoms that can be experienced in dementia and mild cognitive impairment. And yet when you look at this list, it can feel overwhelming, because what we also don't want you to take away is any sort of message that says your loved one will inevitably have all of these symptoms. They may have some, and likely will have some at some point in their illness, but not everyone, as Ashley mentioned, presents with all the same symptoms, nor does everyone present with all of these at some point. And so it's important to take with a grain of salt what you see today and kind of put it in your toolbox, so that if you ever do need it, it's helpful to reference in the future. And then if you are experiencing any of these symptoms with your loved one now, we hope that you walk away with better equipped for how to deal with some of these symptoms. So as Ashley mentioned, we often see depression and anxiety, irritability and agitation, apathy. We can see hallucinations, delusions, and paranoia. Disinhibition and impulsivity can come into play, as well as sleep disturbance, which is incredibly common. There's a term called anosognosia, which just means a lack of awareness of one's own symptoms, as well as repetitive questions and behaviors and wondering. So we're going to tackle all of these today in hopes of empowering you all as you learn how to cope and deal with these symptoms, and also to help normalize what you're dealing with. One of the things that I think about, as Ashley mentioned, as when I was about to have children, there were books galore to read on how to prepare to be a parent. Now that I'm about to have a teenager, which is shocking, again, I'm reading and learning. And so we don't necessarily prep and plan for how to be a care partner to someone with dementia, but we hope to be here to kind of help you in your journey, as it's kind of at your doorstep now. So next slide, I believe, is for Ashley, and she'll get us started with these specific symptoms.
Thank you, Stephanie. So we decided to start with depression and anxiety because it's really one of the most common symptoms that we see, especially early in the trajectory of illness, although we see it throughout the trajectory of illness. The symptoms of depression and anxiety may be similar or different between those with or without dementia. Early in the trajectory of the illness, counseling can be really helpful for the person living with mild cognitive impairment. However, as dementia progresses, patients living with dementia are less able to benefit. And this often comes up. Folks will contact me or Alice or Jenny and with an interest in counseling for their loved one, because of a deep belief that counseling works, I think. And in order for counseling to work, folks have to have the ability to remember, because counseling is all about changing behavior and insight. And so if somebody is at a stage of the illness where insight and memory are both flagging, then counseling is not going to be as effective. However, it is very effective early in the trajectory of illness for most folks, as long as they are interested in it. Pharmacological management is really important. And we do know now, recent studies indicate that a history of depression, particularly unmanaged depression, increases the risk of dementia developing dementia 2 to 4-fold, and is also correlated with an earlier onset of dementia. So for those who are out there who have not developed any kind of mild cognitive impairment, but are aware of depression and or anxiety, it's important to address that, especially in our world. So some of the common manifestations. So how would you know if you're depressed or overly anxious? The common symptoms that we see are tearfulness, kind of a low-lying sadness that's there all of the time. Irritability or withdrawal can be very common. Apathy can also be very common. Agitation depression and anxiety can both present as agitation. Changes in sleep patterns, weight loss or weight gain, and perhaps and all of the above can sometimes be a depression, and they can be other things. Usually thoughts of wanting to die is a classic indicator that depression is there. Some things for caregivers to try. As I mentioned, counseling and psychotherapy. Deep breathing exercises can be enormously helpful for folks living with anxiety. And practicing those on a regular basis, they get more effective the more that you practice them. Same thing with mindfulness practices. Exercise and movement are enormously helpful. And we're going to talk a little bit later about apathy, because sometimes it doesn't matter how helpful exercise is if folks don't want to get out and go. Having a regular routine in place can be very, very, very useful. Increase the amount of time that folks are with others, particularly safe others, quote unquote, folks that they feel really comfortable with. Reminiscence therapy, valuing the whole person, going back and thinking about and remembering the times especially that are stored in long-term memory. And also please be sure to talk with your care provider if you are concerned about your own or your loved one's depression and anxiety, because there are pharmacological things that we can do as well.
Sorry, I was having trouble coming off mute. These dual screens get me every time. We're going to talk a little bit about irritability and agitation, which are incredibly common symptoms. And I would guess if I had to ping one of these items as the ones I get the most calls and portal messages about and spend the most time talking about in clinic, it is irritability and agitation, because of how much it impacts people's daily lives. And to some degree, how hard it is to kind of predict and manage from, well, both a medication standpoint and in terms of just how we interact in communication strategies. It's often related to depression. And so all the things that you just saw in the last slide as warning signs for depression, if some of those are present along with irritability and agitation and reactivity, then our threshold for worrying about the presence of depression goes up. I always tell people that quite often, and Ellie can probably explain this better than I can, but younger folks that we see with depression are often in bed all the time and crying and sad and are overtly depressed. Whereas a lot of our older folks experiencing depression may not show that sadness and tearfulness, but they may be very irritable and reactive and have trouble controlling kind of their mood swings and such. And so it's good to be mindful that depression kind of masks in different ways depending on age and whether or not someone has dementia. It may often be related to circumstances. So when someone is more confused, they can often be more irritable and agitated. When someone is overwhelmed, when they're out of their routine, I get a lot of calls at the holidays because there's chaos and a lot going on, or we're traveling and we're out of our routine. And so oftentimes finding triggers is a really important strategy as well. And it may be, if it's just irritation and irritability on its own, it may not be related to depression. It may just be from confusion and being overwhelmed or being tired. And so looking at sleep as an underlying cause for increased irritability can be helpful as well. There are medications that are available, but studies show that interventions such as communication and adjusting the environment are often more helpful. So in terms of what you see, what I hear most often is that the person may become very reactive or argumentative in conversation. A good fix for that is to not argue. And I know that sounds way easier said than done. But my rule of thumb is that my patients who live with dementia get to be right unless there's a safety reason for them not to be. And oftentimes just reducing the amount of times you try to debate or use logic when someone's upset and reactive can go a very long way. People are also often easily offended or angered, and they may blame or accuse others. And usually it's the loved one closest to them that gets the brunt of that. So learning to kind of recognize that's normal and a part of the dementia can help you in taking a deep breath and not take it personally, and also help you react in a calm manner. You may see pacing, you may hear verbal threats, you may see lashing out physically or throwing items. And again, people may act overwhelmed by changes in routine, environment, noise, and crowds. And so what I kind of commonly hear is we get to dinner with family at the restaurant, and within 5 minutes, my loved one's ready to go. And we never get to finish dinner with the kids and things like that. And so knowing that certain circumstances can be triggers is a really important thing to recognize as well. Some helpful things to try, I've already mentioned some, but keeping track of when the agitation occurs, time of day, what the triggers are, and what worked and what didn't, may help you kind of refine your reactions and also how you adjust the environment to help reduce agitation. It's also really important to understand that all behavior is communication, both your behavior as a care partner and your loved one with dementia's behavior. So it may indicate, if they're irritable, that they're confused or overwhelmed, even if the person can't verbalize that. So rather than saying, "Are you overwhelmed, dear?" maybe try adjusting the environment, taking a break, going for a walk in the middle of a family event or something, and giving that person some space to calm down, and then evaluating whether or not those modifications will help. It's always important to avoid defensiveness and to just apologize easily, which is a practice. This does not come naturally. It is very normal, and I've learned this in parenting. It is very normal for me to correct and tell my children why they need to do something, and to argue with them and debate. And it never works. And so until I made it a practice of saying, okay, I'm not going to argue, I'm just going to redirect, I would run into the same problem. And so learning a practice of is telling yourself internally, I'm not going to defend, I'm not going to use logic, I'm not going to argue, and I'm just going to apologize easily and then redirect, will really help. But it does take work. And so give yourself some grace as well as you try to work through that. Lowering our tone, softening our demeanor. I've had so many patients over the years who've benefited from music and massage. One of the places we see agitation a lot at later stages is in reaction to self-care, like bathing and dressing. I had one lady whose caregiver at her personal care home turned bath time into spa time, and they would turn on music and have a fluffy robe and do a massage. And they really just said, it's your spa treatment. And it helped her so much with calming down and not being as reactive, because she saw that person as a spa staff and not as someone forcing her to get a bath when she didn't want it. And then really critical to understand here is that if you ever do hear verbal threats or see physical lashing out, or if you just personally feel like you're in danger or your loved one is, you need to have a safety plan. You need to know to remove yourself from the environment and to be able to call help, usually 911 if it's a critical situation. And also don't be afraid to talk to your care providers if you're seeing this repetitively for advice and guidance.
All right. Well, thank you everyone so much for allowing me to be a part of this today. My name's Ellie Santee. I'm one of the geriatric psychiatrists here. And I'm going to be talking a little bit about apathy, which is actually the most prevalent behavioral and psychological disturbance of dementia. And I'm sure you all can identify with that. And it's not only frustrating for the person living with dementia, but also really frustrating for the caregivers and loved ones. And so apathy causes the person to have little or no motivation to do things that they would usually or used to find meaningful and worthwhile. About 2 to 5% of older people in general without dementia have apathy, and about 50 to 70% of people with dementia have apathy. And those are really large numbers. And it can be a symptom of depression, but doesn't have to be. It can also occur as a single entity. So it's really important to think about this and talk to your care providers about it. So some common manifestations are lack of energy or motivation to do routine or daily tasks, such as brushing teeth or showering, relying more on other people to suggest and organize activities, not interested in joining conversations or talking to new people, and maybe just not interested in talking at all, seemingly unconcerned about their own problems. And I think one that can be really triggering for loved ones and caregivers are emotional responses to news, unemotional responses to news or personal events. And they, can seem very uninterested or detached to news that when they were not struggling with their memory or thinking would have, been really exciting news for them. They might not have that same reaction. So some things to try. Begin activities and encourage the person living with dementia to join you. Often initiating an activity is the biggest barrier. It's also important to break down tasks into simple steps. Sometimes apathy is a function of challenges with executive function, which we see a lot with people living with dementia. Invite your person to help with tasks, so make it fun or try to be creative with it if you can. So like teamwork, be my sous chef tonight. So maybe inviting them to help you cook dinner or help prepare in some way would make them feel more involved. Incorporate more structure and routine. This is always really helpful. Expand support network to provide additional opportunities for engagement. And I think Stephanie has shared before, a friend might ask your loved one to go on a walk every day, and they're not going to go unless that friend actually comes, gets them, and walks with them. They have to really be initiative. And then request care provider to assess for depression, because it could be that something more than apathy is going on. And even apathy has pharmacologic treatments. If you've tried all of these non-pharmacologic agents and they're still just really apathetic and maybe not even wanted to go out of the house during the day.
Right. Hallucinations, delusions, and paranoia. A lot of times, one of the main questions I get is, what is a hallucination versus a delusion? And how do we really understand what's going on and what to worry about, and so on and so forth? Surprisingly, up to 44% of people with MCI and dementia can experience hallucinations and delusions. And they may or may not be disturbing to the person. So it's also important to recognize that these can be quote unquote normal symptoms of some people's disease, especially those with Lewy body dementia. And intervention and treatment is really dependent on how upsetting, disturbing, and or threatening these types of symptoms are. And again, we often see it most commonly in Lewy body dementia. One thing that I do in Lewy body dementia for people who have hallucinations is to try to normalize that for them. That's Lou playing tricks on you again. And a lot of times that's really comforting to my patients to go, oh yeah, those guys that hang out in my living room in the afternoon, they're just part of my brain disease, and I don't have to worry about them. And so to some degree, normalizing it there's a fine line between normalizing hallucinations and delusions and arguing about them or trying to correct. And so we have to find that balancing act and also see what our loved one responds to the best. Quickly, hallucinations are actually seeing, hearing, smelling, tasting, feeling, or sensing something that other people don't. So if you're next to your loved one and they look down on that busy oriental rug and they see bugs crawling everywhere, that's a hallucination. If they look outside and think there's someone running towards the house to break in, that's a hallucination. If they're sitting at home and they believe that the kids are coming for dinner, but they don't actually see children running in the door, then that's a delusion. And that's really a belief that a reality is happening that's different from what others are experiencing. If your loved one is setting the table for 8 people and it's just the 2 of you that night, they may be having a delusional thought that someone's coming, or they may be remembering past experiences that now feel very real to them, like when the table was full with lots of children. And so recognizing the difference in those can help you in explaining it to your care provider if there's concerns, and also can help you understand what might be going on in your loved one's mind. There's also a flavor of delusions that can lead to paranoia, where people believe someone's out to get them. And this often manifests as people stealing things from someone or trying to hurt them when they need to do self-care type activities. And so it's often why in late stages we see a lot of combativeness, because that person feels very fearful when care staff or loved ones come in to try to give them a bath or help with care activities. We also see it a lot, like I said, when people start to lose their items that they love, and they can't explain it logically because they don't remember losing their item. When I lose my keys, I know I lost my keys. But when you start to lose a lot of important things and there's no logical explanation in your own mind because of your forgetfulness, it can lead to some paranoia and accusations. And again, these symptoms may or may not be troublesome, and so it's important to gauge that. Distracting and diverting is one of the all-time best ways to deal with this. I tell people, don't jump on the train with people. Don't start asking 1,000 questions about their delusions and hallucinations, because you'll just be stuck in the middle of a conversation that's not real to you, and you don't know how to engage it. Rather reassure their feelings about it. So if someone is fearful that there's something going on outside, then maybe you reassure, oh, I'm going to look into that. I'm so sorry that you're scared. Let me check on that. And then maybe go quietly, close the blinds, step out of the room, go to the bathroom, come back, and maybe come back with a bowl of ice cream and change the subject and see if redirecting and distracting and not re-engaging will help just cut it off at a pass before it gets to a more escalated moment. And again, trying to correct or talk someone out of their belief or experience that differs from yours usually does not go well. And again, it's okay to let it stand if it's not threatening their safety. It does sometimes escalate to a threat and safety, and you do need to contact your provider if this becomes a repetitive occurrence that really escalates to a point that people do not feel safe. One of the things we talked about at GMN was how you can use improvisation to really help in these situations. And so sometimes it's better to just take a deep breath. And again, this takes some exercise and training, but to try to really respond in ways that, again, may make it reassuring and may make someone feel not so scared by having, I wouldn't say have fun with it, but try to enjoy a way of distracting or changing the tone of what's going on.
And just to add on, thank you, Stephanie. And just to add on to that, one of the folks who spoke at the Georgia Memory Net conference spoke of her mom's delusion or hallucination that there were men in scary black robes that had felt really threatening. And I thought it was really lovely that the family redirected that and said, "Oh yes, those are the people we hired to protect you," and moved on. But that took the fear away from that hallucination and turned it into something that helped the person feel safe. So I think that there are different ways. Again, some improv and kind of being flexible, and sometimes I call it keeping our knees bent, being able to go in any direction when those hallucinations and delusions pop up, and we have to kind of figure out, and they're troublesome, either to us or to somebody else. Moving on to disinhibition and impulsivity. I think everyone probably here in the audience knows that persons with mild cognitive impairment and dementia sometimes act impulsively and or lose their inhibitions socially and sexually, or act rudely or insensitively. We see this in all kinds of different reports. You know, I don't want to take my loved one to the grocery store because he says things to the person at the cash out register, or will say things, will comment on people's appearance in a really insensitive way. This behavior change is common for, it is certainly not uncommon for anybody with MCI or dementia, but it's particularly common in those that have disease that affects the frontal lobes, including frontotemporal dementia. The impulsivity can also really be one of the very first things that folks recognize and see with sort of a different behavior and being easily scammed, kind of impulsively jumping in with gambling or high risk activities. The frontal lobes of the brain are responsible for a person's ability to focus, to be able to pay attention, and to be able to be motivated. So that filter, when the frontal lobes are affected, our filter is often goes away. Some of the common manifestations, I mentioned some of these. Folks will ask personal or awkward questions, or share private information. There can sometimes be an inability to, or at least a decreased ability to recognize social cues. Sexually explicit comments, sometimes touching themselves or others inappropriately. I have the incredible, it feels like an honor to me to attend the FTD caregiver support group every month. And something that is common, at least that I hear about a lot, is frequenting strip bars, gambling, porn. It can also show up as cutting in line or driving really aggressively, eating off another person's plate. And interactions with law enforcement actually can be a huge indicator of this particular symptom. And in fact, there's some studies about folks with frontotemporal dementia, which typically shows up a little bit earlier, that many of their first interactions are with law enforcement before they realize what the disease is. And there's also a fairly large percentage of individuals with behavioral variant frontotemporal dementia, or any of the dementias that are particularly affecting the frontal lobes, of divorce before recognizing that it's an illness, that the behavior change that they're seeing, the personality change, is caused by FTD or another one of these illnesses. So some things that have been proven to work, that care partners can do. Logging impulsive behaviors to just better understand what the triggers are. Again, all behavior tends to be communication. So if we log the behavior, a lot of times we can figure out what the communication is. Forewarning family and friends and law enforcement of the person's behaviors to better prepare them. Several of the members of the FTD support group have taken their loved one down to the police department and introduced them and explained what was going on. And that has come in really handy on the backside when, if something happens, the law enforcement in the area know the patient and know what's going on, understand what's going on. Keeping the person engaged in other activities to avoid those impulsive responses. That contented involvement. Awareness cards can be enormously helpful. Little business cards that you can slip to somebody that said, my loved one, please be understanding, my loved one has dementia. We also see particularly conservatorship as become necessary, or at least families feel that it's necessary for folks who continue to impulsively spend money and there doesn't seem to be a way to kind of bring that back under control. And then having a sense of humor is vital. Just being able to just laugh and not take things quite so seriously, to kind of stay in the moment has proven to be really fun. And support groups are a great place to do that, to just be able to laugh with others who really get it, that this is definitely not an easy journey, but we can laugh at ourselves. So I'll turn it over.
All right, next we're going to talk about sleep disturbance, which again is a very, very common symptom that affects not only the person, but their caregivers. So studies show that around half of persons with MCI and dementia experience sleep disturbance, most often difficulty falling asleep and or staying asleep. This could be because they confuse night and day, but sleep really impacts everyday functioning. It impacts our mood, irritability, anxiety, hallucinations. It kind of impacts all of the other behavioral and psychological symptoms of dementia that we've discussed. And so a lack of sleep often makes all of them worse. And actually, sleep disturbance can be a major contributor to facility placement, because if the person living with dementia is not getting sleep, you all know that the caregiver or loved one is not getting sleep either. And that if we don't get sleep, that just raises everyone's irritability. So some common manifestations, like we've kind of discussed a little bit, are difficulty with falling asleep, difficulty staying asleep, early waking, and there might be some type of evidence that the person was up in the middle of the night. You might go out and find that the living room light was turned on when you knew that you turned it off. There might be used dishes in the kitchen. And also the person might have excessive daytime sleepiness or a lot of fatigue. I see a lot of patients who are really fatigued throughout the day, and it's because they are not sleeping at night. So, we try to get them back on a regular sleep-wake cycle as much as we can. There also could be abnormal movements associated with a lot of the different diseases and dementias. So restless leg syndrome, periodic leg movement syndrome, and then REM sleep behavior disorder, which is really common in people who have Lewy body dementia or Parkinson's disease dementia. And that's where they act out their dreams. So they might be thrashing around in the bed a lot at night. They might accidentally punch their loved one. They might accidentally fall out of bed. And oftentimes REM sleep behavior disorder can occur even before the person has dementia. Other manifestations are abnormal breathing patterns, such as snoring or apneic events, which are usually indicative of OSA, which stands for obstructive sleep apnea, and would indicate that they would probably benefit from a sleep study. And so apneic events are when someone is sleeping and then kind of wakes up at night gasping for air. And another, probably the most common manifestation, is caregiver exhaustion. So some things to try: as much as you can, keeping a consistent sleep schedule. So our body's natural rhythm for sleep is to go to bed around 11 p.m. and wake up around 7 a.m. So if you could really try to stick with that, that would be wonderful. And I know that's hard, but can be really beneficial. So practicing good sleep hygiene techniques, which would be things such as limiting screen time an hour before bed. So, no television, iPad, computer, and trying to do things to calm down. That could be drinking some warm tea without caffeine, of course, or taking a hot bath or hot shower. And then, like I said, addressing any sleep issues that could exist, like OSA, which would mean having a sleep study done. And then, like I said, trying to settle down before bed. So do some calming activities. I know that Ashley mentioned earlier, like deep breathing exercises. You could try every night for that to be a practice that you do, specifically before bed, because we know that the more you do deep breathing exercises, it lowers your anxiety level. So establishing a safe sleeping environment is really important for people who have REM sleep behavior disorder. And that's the one that I said where those folks act out their dreams. So, and can sometimes fall out of bed. So, you know, it can be important to establish the room in such a way that if they fell out of bed, they weren't going to hit their head on a table. Melatonin with approval of care provider is also something else to try, especially with folks who have Lewy body dementia or Parkinson's disease dementia. There's a lot of data and evidence to support that it can be really helpful. Melatonin is actually, it's a hormone that our bodies produce naturally to help regulate the sleep-wake cycle. So it's really safe. You can actually purchase it over the counter. But again, I would probably talk about it with your care provider first. And then, you know, if you've tried all of these methods, neither one of you are still getting any sleep, I would definitely discuss it with your care provider, because there are other medications and tools to help.
So I mentioned earlier this term anosognosia, which simply means a lack of awareness of one's own symptoms. And I've said for a long time that in at least my practice, I can almost directly correlate how anosognosic a person is with the amount of stress and burden that the care partner experiences, because the less awareness someone has of their symptoms, the less willing and able they are to kind of come along with suggestions that are needed for things like driving and financial management and help with medications. And so there's just a tendency to be a lot more reactive and argumentative when someone doesn't recognize that they have dementia symptoms. Arguably, almost everyone living with some form of dementia has at least a slight degree of anosognosia. And some people have complete anosognosia where they have almost no awareness at all. And so it's definitely a trajectory or spectrum. And it may be specific to a certain area of their thinking, or it could be global in all of their symptoms. And again, it's important to remember that it is a neurological difference, a symptom of their disease and not a choice. And it is not, while denial can be something that people go through, anosognosia is not denial. And so we have to address it differently than we would denial. A lot of times people struggle to acknowledge or be aware of their limitations. And therefore they insist on maintaining independence. And while we definitely want to come alongside and help people maintain as much independence as they safely can, as you all know, there comes a time where it's not safe to drive anymore. It's not safe to manage finances or medications because the risk of mistakes and safety issues. One of the ways I try to normalize this in my clinic is I tell my patients that almost everyone I've ever met in all my years here ends up retiring from driving at some point. And so helping normalize the fact that some of these types of things that we've done independently our whole lives will inevitably come to a point where we need support, and we'd rather, especially early in disease, have our loved ones have some decision-making interaction over these, how we hand over finances, how we decide to give up driving, and how we still get around and all of that, rather than waiting for there to be a crisis. These people are often argumentative and disagreeable in discussions or when trying to make decisions or share responsibilities. And probably the biggest trigger is driving. I love the older gentlemen I have who they used to look at me when I was young and say, "What are you in your 20s telling me not to drive? I drove fighter planes for years." And so there's just this disconnect that can be really, really difficult, and it can lead to a lot of care partner and caregiver frustration. Again, trying to convince someone or use logic and reason in the person living with dementia, especially in the person living with dementia that doesn't recognize their symptoms, is usually the equivalent of beating your head up against a wall over and over again, because they aren't aware and they're not going to be. And so no beautifully crafted explanation you give that's logical is always going to work. However, if we don't confront and we distract or divert, or we blame it on something or somebody else when there has to be an intervention, we can often create a situation that's successful. And so one of the people I love dearly told me that, one of the ways she deals with her husband not wanting to have a caregiver in the home when she has to go to an appointment or, God forbid, a dinner out with friends, is that she just schedules that night for him to go have dinner with her daughter. And so rather than confronting, hey, you need somebody to be with you because you're not safe, she just says, hey, tonight our daughter invited you over for dinner. She just wants some time with her dad. And then she goes and does her thing. And so you're not having to constantly battle with the lack of awareness of why you'd need a caregiver. And the same thing goes with needing to bring someone in the home. We often hire somebody to clean the house that's really there to provide supervision rather than making it about the person's symptoms. And I think those are really good key things to take away from this symptom.
We're going to finish up. We have just a couple more, and then we'll take questions from the audience. So please be sure to put your questions in the Q&A section. Speaking of, repetitive questioning and repetitive behaviors is a very common symptom early and middle stages of the disease, especially in those with Alzheimer's pathology, interestingly enough. And it comes from a couple of different things we know. One is that there's a memory storage problem, and Stephanie often says the save button isn't working like it was before. So recent memories, recent events are not always stored. And so we get this repetitive questioning and repetitive behaviors. It can be exhausting for care partners, especially in the beginning, just saying it again and again and again. And it's also with that save button being broken, it's also a desire for our loved one. Our loved one has to be in control and to know what's going on. So asking repeatedly about events, when am I going to the doctor? When am I going to the doctor? When am I going to the doctor? One really helpful thing that lots of people have tried and reported good results with is not talking about events until they are a day away. So if somebody doesn't know they're going to the doctor in a week, they can't ask you about it every day, 8 times a day, every day, or 8 times a minute, every minute between now and next week. Repeating the same story and kind of getting stuck in a loop can be a part of this. Repeating conversations or having absolutely no recall of recent events. So we've had the conversation and then we have the same conversation over again. The other piece of this that goes with this, and sometimes people don't realize that the two are related, is those repetitive or compulsive behaviors, like checking locks on doors or window coverings over and over, having pacing all around the house. One of the clients that I get to work with paces constantly, and goes to an adult day program and paces at the adult day program, and somewhere along the way somebody put a Fitbit on, and he walks upwards of 11 miles a day pacing, and the biggest challenge is to keep weight on him. Collecting or hoarding items, counting, organizing objects repeatedly, and going to the toilet frequently. So that's one that can be really challenging to folks because they just feel like they're constantly taking mom back and forth to the bathroom. Some things to try: whiteboards, understanding. I often say with whiteboards or calendars made of whiteboards, the trick is to remember to look at them. And the bathroom is a really good place where everyone tends to go. And so having the whiteboard in the bathroom can be really helpful for some families. understanding that it is not purposeful. And that can be a real trick for a lot of us, because about the 20th time that you've answered the same question, it's really hard to remember that that our loved one would not be asking that question 20 times if they could help it. When technology can be helpful for some folks. And then seeing if there's a way to substitute the behavior with other activities, like maybe exercise, or with things. I have a client who likes to organize things, and was organizing her husband right out of the house because he could never find anything. And just sort of off the cuff, I just said, well, how about socks? Can she organize socks? And so every morning he gets up and mixes up all of his socks, and she spends the morning, several hours of the morning, pairing up all of his socks. And they do that every morning because she doesn't remember the next day that she's done that. And it's worked like a charm. And then remembering that sometimes that repetition is actually a desire for connection. So it's a way for folks who are anchoring on their care partner to be connected, and that what they're really asking for is reassurance. And so if we provide that reassurance, we may not need to continue to answer that same question again and again. We may be able to provide that in a different way. Ellie, I think you're up.
Yeah, so I think the last symptom that we're going to discuss today is wandering, which is a scary one. So persons with dementia sometimes wander, which is walking away. They become disoriented. This can also happen when driving. And this can be one of the scariest symptoms for caregivers. And I think this is so true that persons living with dementia do not wander until they wander. I had a patient recently who has had Alzheimer's disease for years now, but wandering was never an issue until it was, and she wandered in 3 weeks. So the family very quickly had to make some changes. So some common manifestations are wandering away from home or away from others if they're in a different type of gathering, wanting to go home even when they are at home because they don't realize where they are and are confused about where they are, getting lost while driving, and then not remembering leaving or where they have been before. So some things to try. Smartphones, Apple phones, whatever, they usually have a tracking device on them, and that can be really helpful if the person has it on them. So I had a patient recently who got up in the middle of the night and drove when he is not supposed to drive, and no one knew where he was because he didn't have his phone on him. So typically they rely on that app on the phone, but that can only help if the person is carrying it. There's also a great organization called projectlifesaver.org, and it is, oops, sorry about this. Let's see my screen. Oh, cancel. Sorry. Can you all see this? Something popped up. Oh, you can't? Okay. Anyway, sorry about that. Something popped up on my screen. So projectlifesaver.org is an organization that will provide a ID alert bracelet. And I think typically it can be county to county through maybe the police office department. So you could call your local police department and see if they participate in this. There are also medical alert ID bracelets that you can purchase. I know the Alzheimer's Association, you can purchase one through them. There are a variety on Amazon that you could get. Kind of already talked about GPS, GPS for if the person is still safe to drive, or there's also GPS just on your phones to locate you. Another important trick that can really work is to put the locks on doors at higher or lower than their eye levels, so that when they go to walk out the door, they won't see that it's locked, and would hopefully get distracted and move on. Of course, bells on the door, cameras, alarms, all of those can be really helpful, especially if the person is living alone or doesn't have a caregiver at all times. I've had a lot of patients utilize that, and it's been really helpful, or their caregivers more so utilize it. And so for persons who are never alone, you could double bolt locks, and with the caregiver though always having the key. And then like Stephanie and Ashley have both discussed, helping the person retire from driving. It's never an easy topic, especially for loved ones and caregivers, because typically the person living with dementia blames them. So I think we all try to put the blame on ourselves and be like, we are the ones telling you that you are not safe to drive. I think that's our last slide.
Yeah, a few resources here. I know a couple of people have asked, are the slides available? We'll be glad to send a PDF of the slides out to everyone. I think we have everyone's email address because I think you have to sign in with it. So we'll be glad to send it out. A lot of this material has been developed over time, but a lot of it's also from the Savvy Caregiver program developed by Ken Hepburn. If that's something that you're interested in taking, it is a 6-week program on Zoom for 2 hours a week. It's a pretty big time commitment, but it's all about how to be a savvy caregiver. So it's specifically for caregivers of individuals with dementia, not so much mild cognitive impairment, but really with dementia. You can contact me. The email address is there, or if you're in part of the integrated memory care, you can contact Jenny Gay or Laura Metters, and they will get you on their waiting list. There is now a clinical trial out that is Telestella that Emory is participating in at the Oregon University of Oregon or Oregon State. I think it's University of Oregon is the primary on that, and some other resources. But other questions, Jenny?
Hey everybody, that was such a phenomenal presentation. Thank you all so much for everything you brought to the presentation today and for sharing your knowledge with us. So in terms of questions, I think Ashley addressed this. Several people asked, will the presentation be available later to share with others? So it will be, and it will be emailed out to folks.
So Jenny, just to correct, the slides will be emailed out to folks.
I'm sorry, the slides will be.
Recording will eventually be available on our new education webpage, but
Okay.
I'm not sure when that webpage is going to go up.
Okay. So the slides will be available and will be emailed to you. Sorry, Ashley. A question that we have in the Q&A is, new behavior since my loved one fell in May, going to the bathroom every 20 minutes. I'm not sure who wants to field that question, but
I'm happy to, unless somebody else wants to. The number one thing that I always tell people is when someone is frequenting the restroom, you always want to rule out a medical cause first. And so talking to your primary care provider about the symptom and figuring out whether or not there's an infection or possibly some sort of structural urologic problem that can happen with age, or especially if there was a hip fracture, there may be something structurally that's causing some bladder irritation or something like that. And so it's important to follow up medically first. If that's been worked up completely and it really is more of a kind of obsessive repetitive behavior, it's one of the more challenging things that I've run into. And using distraction, using music, kind of having the person in a room that's kind of not close to the bathroom where it's not a visual reminder, because if you're sitting at the television and you can see the bathroom straight across the hall, then that might trigger someone to want to go over and over again. So kind of structuring the environment or trying to break up the day with frequent little walks and things like that, just to try to help that person not be so focused on the bathroom trips can be helpful. But it is challenging. And I also tell people a lot of these symptoms are phases, and sometimes you try every intervention and nothing works, and then suddenly you wake up one day and they're not going to the bathroom 20 times. And so time sometimes is our best healer as well. I don't know if Ellie or Ashley have any other tips on that one, but those are my first thoughts that come to mind.
I think that for me, that covers it. The distraction piece is helpful after being medically cleared, right? And then for some folks, they've decided that they'd rather go every 20 minutes than clean up accidents, so they reinforce that. They'd rather help. Any other questions? All right, y'all. Jenny, Alice, Stephanie, Ellie, thank you so much. It's just such a privilege to work with y'all. Really appreciate it.
Guys, an excellent presentation. Thank you. We see you
Take
guys
care.
next month.
Thanks for having us, everybody. Be well.
Thanks for attending.
everyone.
Bye-bye.
Bye-bye.